Emphysema is a chronic obstructive pulmonary disease characterized as a permanent abnormal enlargement of the distal air sacs in the lungs. The pathophysiology of emphysema is initiated or exacerbated by continuous exposure to air pollutants causing oxidative stress irritating the inner lining of the lungs and alveoli. There are 4 different types of emphysema: centriacina, paracina, paraseptal, and paracicatrisal emphysema. Emphysema develops over long periods and is caused by smoking, dust, air pollution, and certain occupations where there is constant exposure to these factors. Emphysema can also result from a deficiency of alpha-1 antitrypsin, which is a protease that inhibits the enzyme neutrophil elastase and is responsible for the prevention of infection. And without this protease inhibiting the enzyme's activation, neutrophil elastase can destroy the elastin and collagen in the parenchyma in bronchioles and alveoli, leading to emphysema. And this deficiency is common in younger people. In relation to Michael, his continuous cigarette smoking and exposure to air pollutants from working at a construction site are likely the cause of his development of emphysema. Smoking-induced emphysema occurs from the irritation of excessive exposure from cigarette smoke, and this leads to 2 factors: the inactivation of the alpha-1 antitrypsin, which protects the lung tissue, and also it initiates the activation of the inflammatory process of chemotaxis from macrophages, neutrophils, and T lymphocytes. The release of these immune cells in the parenchyma initiates phagocytosis on the inhaled oxidants and release proteolytic enzymes such as elastase and protease, and these begin to build up in the alveoli. These proteolytic enzymes directly damage the alveoli walls by breaking down elastic tissue and collagen. Additionally, they release the tumor necrosis factor alpha, which is an inflammatory cytokine from macrophages, and this causes further destruction to the alveoli walls. Apoptosis also occurs in the parenchyma of the lungs and is mediated by the T lymphocytes. This contributes to the further breakdown of connective tissue in the alveoli walls. As the destruction of the alveoli walls occur, pulmonary capillary beds also decrease in surface area, impairing their mechanism of gas exchange between the alveoli and capillaries. Additionally, the activation of the inflammatory system from smoking triggers goblet cells hyperplasia and a decline in ciliate cells. This provokes an increase in synthesis of mucus and a decrease in sputum hydration and clearance, resulting in hypersecretion of mucus, which can build up and obstruct the airways, reducing airflow. From the loss of elastin in the septa of the alveoli and lung tissue, this decreases the size of the smaller bronchioles and decreases radial traction, which holds the airways open, and there is also an increase in pressure outside the bronchial lumen. These changes increase airway resistance and decrease airflow into the lungs. The decrease in elastic recoil also decreases the rate of expiration, and together this and the altered airflow can result in air trapping. Air trapping occurs in the distal ends of the alveoli because of the elastic recoil cannot remove all the air from the lungs. Hence it gets trapped, leading to the air sacs to become distended. This can lead to alveoli hyperventilation and hypercapnia from impaired ventilatory mechanisms. Air trapping also increases pressures applied to the bronchioles and results in them collapsing from airway and forming airway obstructions. In the parenchyma of the lungs, large air-filled spaces called bullae can form from the destroyed lumen and the air trapped in the alveoli. The bullae impair gas exchange mechanism in the alveoli and capillaries and can induce hypoxemia in extreme cases. Hyperinflation can then also occur in the lungs from air trapping in the alveoli and the decrease in lung elasticity and recoil, increasing the work of breathing and demanding the use of accessory muscles such as the diaphragm for respiration. These pathological changes that occur manifest as dyspnea and can occur from minimal exertion from air trapping and limited gas exchange. wheezing from inflammation, and narrowed airways, as exhibited by Michael's presentation, are also seen. The pathophysiological changes of emphysema are permanent and cannot be reversed. However, there are medications that are used to relieve the symptoms and prevent exacerbations. One medication used in the management of emphysema is long-acting beta-2 adrenergic receptors selected agonists, also known as LABAs. LABAs are bronchodilators commonly used for asthma in both emphysema and bronchitis. It is used as a long-acting symptom controller as it facilitates prolonged relaxation of the smooth muscles, therefore improving airflow. It is also used twice daily to improve dyspnea, reduce exacerbations, and number of hospitalizations. An example of a LABA is salmeterol. Salmeterol is a long-acting bronchodilator used to relieve bronchospasms, and it approximately lasts 12 hours and administered through inhalation. The medication stimulates the beta-2 adrenergic receptors in the smooth muscle of the airways, which causes an increase in the intracellular cyclic adenosine monophosphate levels to stimulate alveolar fluid transport, causing smooth muscle relaxation and bronchodilation. Adverse reactions include the stimulation of alpha and beta 1 receptors in the body, which cause tremors, tachycardia, palpitations, vasoconstrictions, and headaches, also are an adverse effect. Nursing considerations of this medication is that its onset is 30 minutes, hence it is not ideal for acute exacerbations. It is also important to monitor hyperkalemia as this can occur from high doses of beta-2 agonists. Other considerations also include monitoring patients' vital signs, especially respiratory rate, heart rate, and also performing respiratory assessments to assess lung sounds. Thank you, and these are my references.